Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion on diffuse lung diseases, we are going to be talking about pulmonary vasculitis and iatrogenic lung disease today. So let's start off with pulmonary vasculitis. As the name implies, itis is inflammation, vascular means blood vessel. Therefore, pulmonary vasculitis would include a group of inflammatory conditions involving small vessels, large vessels, and there's also a granulomatous component to this. The imaging manifestations would include alveolar hemorrhage because of the small vessel involvement and nodular foci which may cavitate. So let's begin with microscopic polyangiitis. It's the most common cause of pulmonary hemorrhage with rapidly progressive renal failure as part of the pulmonary renal syndrome. Now, P-ANCA is positive. Alveolar hemorrhage only occurs in about 20 to 30% of patients. And due to the hemorrhage, imaging features would include diffuse central predominant ground glass opacities. So this axial CT shows basal predominant central ground glass opacities with associated mild interlobular septal thickening. Now, this patient had renal insufficiency and had a P-ANCA positive vasculitis with alveolar hemorrhage. The next one is granulomatosis with polyangiitis. This was formerly called Wegener granulomatosis, and it's a systemic small vessel vasculitis which has a classic clinical triad of sinusitis, lung involvement, and renal insufficiency. This one is C-ANCA positive as opposed to P-ANCA positive in microscopic polyangiitis. In the upper airways, GPA may cause nasopharyngeal and eustachian tube obstruction. Lower down, the larynx can also be involved. The bronchi can also be obstructed, and this will lead to airway stenosis, most commonly subglottic airway stenosis. Then lower down again, in the lung parenchyma, GPA may cause multiple nodules, often with ground glass halo in the acute setting, and we know that the ground glass halo represents some pulmonary hemorrhages. These nodules may also cavitate. So this axial CT shows multiple thick-walled cavitary lesions, and the left one here shows a small ground glass halo around it, which could suggest hemorrhage. The primary differential for this is septic emboli. However, this patient was C-ANCA positive, so that brought granulomatosis with polyangiitis on top of our differential list. Then we are moving on to iatrogenic lung disease, under which we'll talk about drug toxicity and radiation-induced lung injury. So for drug toxicity, we know that the lung has diverse but a finite repertoire of responses to injury. We have looked at a lot of these responses to injury over the past maybe 20 videos. Some of these include pulmonary edema due to increased capillary permeability. We've seen ARDS, we've seen organizing pneumonia, eosinophilic pneumonia, bronchiolitis obliterans. We've seen pulmonary hemorrhage, non-specific interstitial pneumonia, and usual interstitial pneumonitis. We've seen all these patterns of lung disease, and the fact of the matter is pulmonary drug reaction, most commonly to cytotoxic drug, may elicit any of these injury responses. Then to radiation-induced lung injury, up to about 40% of patients who have radiation-induced lung injury would develop radiographic abnormalities after external radiotherapy. However, most of these patients are asymptomatic. The radiographic abnormality is often, but not always, confined to the radiation port, the direction of the radiation beam. It follows a non-anatomic pattern most of the time. So you would realize that it is confined to linear margins that are not necessarily anatomic. So first off, we'll mention radiation pneumonitis. This is the early stage of radiation injury, and this can occur within 1 month of radiotherapy, and it's most severe 3 to 4 months after treatment. Radiation pneumonitis features ground glass centered on the radiation port. That's the direction of the radiation beam, although extension out of the port is relatively common. So in this image, we see acute radiation pneumonitis, this coronal and axial CT, and these demonstrate geographic left upper lung ground glass opacities with non-anatomic superior margins. This is not following any anatomic margins. This is not where any of the fissures is. And then we also have a non-anatomic lateral margin, also not following any anatomical landmarks per se. And you realize it seems to be extending from anterior to posterior, likely in the direction of some external beam radiation. Let's note that radiation-associated findings may cross fissures. Then from the pneumonitis, we move on to fibrosis. Radiation fibrosis is the late stage of radiation injury, and the fibrosis becomes apparent approximately 6 to 12 months after the therapy. Now, the key imaging finding is the distribution of fibrosis and traction bronchiectasis within the radiation port. Although, again, fibrosis may extend outside the port in about 20% of cases. So in these images, this chest radiograph and contrast-enhanced CT, we see paramediastinal fibrotic changes within the radiation port. Here, you can see these areas of bronchiectasis and fibrosis. There's also this persistent adenopathy here despite the radiation, but that's not what we are discussing today. We're talking about the radiation-induced fibrotic changes here. All right, so that brings us to the end of this discussion. The next thing we'll talk about is pulmonary sarcoidosis. I hope you have found value from this discussion, and if you have, give it a like, comment, share to someone who might need it, and subscribe if you have not subscribed yet. And I will see you in the next one.